Hello, welcome everyone to our webinar, Knowledge is Empowerment. Thank you for joining us today. We hope you will find the information valuable. This webinar is part 2 of a 3-part series that we've been working on. And when I say we, it is the American Autoimmune Related Disease Association, Clara Health, IFAA, the International Foundation for Autoimmune and Inflammatory Arthritis, and the Purple Playas Foundation. In case you missed it, our first event was our Condition Confident Twitter chat, and our next event will be after this. It'll be a Facebook chat on Friday, April 5th at 3 p.m. Eastern, using the same hashtag Condition Confident, where we keep the conversation going on how knowledge can be empowering to people with chronic illnesses, especially those with a rare disease, and being confident in their condition so that they get the best possible treatment and care. And we will have more information on that a little bit later. Before I begin, I just want to let everyone know that you don't need to take any notes. We will be sending out all the content from today's presentation so that you won't miss a thing. Our goal today is to equip you with the knowledge to empower yourself in getting the best possible care and the best possible treatment for yourself so that you can live your best possible life. I'll let everyone introduce themselves when we have some amazing guests today. But my name is Katie. I am the project manager for AARDA, the American Autoimmune Related Diseases Association. It is very common for us to hear from patients with multiple autoimmune diseases and many people seeking to get a confirmed diagnosis. Unfortunately, it's the nature of autoimmune disease to be difficult to get a diagnosis. They're commonly misunderstood and they commonly overlap with other conditions. But now I will turn it over to Tiffany from the International Foundation for Autoimmune and Autoinflammatory Arthritis, who will start us off by discussing the overlapping complexities of diseases and hard to treat autoinflammatory arthritis.
Okay, great. Thank you so much, Katie. As she mentioned, I am Tiffany Westridge-Robertson. I am the CEO of the International Foundation for Autoimmune and Autoinflammatory Arthritis, or IFAA for short. And I am also a person living with these diseases, as are most everybody who helps run IFAA. So we're happy to be here today. This is a very important topic for us, as one of our core priorities as a organization is to focus on early detection, referrals, diagnosis, treatment, which then ends in better outcomes and higher rates of remission. So if you want to forward the slide there we go. AI arthritis, as we call it for short. So essentially, there are 100 plus autoimmune diseases or autoinflammatory diseases that have arthritis as a major component, and but only a certain amount of those have the arthritis as a commonality. If you want to forward, Katie, just you can forward a few more there. There we go. And so essentially, we were founded because we recognized a need through communicating with hundreds and thousands, really, of patients all over the world who have these similar onset stories. And it was the autoimmune features, or the autoinflammatory features of fatigue, fevers, various rashes. So those were all commonalities. But like I said, there's over 100 of those diseases. And then the unifying factor was we all still had arthritis as a major clinical component early in onset. So 20 plus diseases may include it as a major clinical component early on, but less than 10 actually included almost always as a major clinical component early in onset, or even as an initial onset symptom. That's when we had kind of this light bulb moment and said, you know what, if we really want to focus most of our efforts on early detection and changing the stories of tomorrow to be those of better outcomes and higher chances of remission, maybe we need to form a nonprofit that focuses just on those diseases. So that's really how we were founded and why we're here talking to you today. One of the things that is really important for us to understand is by communicating, we really are going to be able to identify further the similarities and differences between these diseases. And then there are also those that mimic our diseases. So one of the example that I wanted to talk about that mimics our diseases is so rare that it actually could be overlooked, or we may be misdiagnosed with an autoimmune arthritis or an autoinflammatory arthritis disease. One such example is called Farber's disease. It's actually caused by a genetic mutation. The onset is typically early in infancy, but later in life it can also happen. And it has been confused with juvenile arthritis because the symptoms include arthritis, swollen lymph nodes, swollen joints, joint contractures, in addition to some other things that maybe aren't typically associated with JA. And I wanted to really focus on that word too, typical, because we're going to talk about that a little bit more today. That typical versus atypical, so key for us to really communicate and understand when we're talking about early detection, what does atypical and typical mean? So if we understand the similarities and differences, it's really an essential piece to early detection. And a big part of that is going to involve the communication, talking and sharing experiences. And that's what IFAA really specializes in, this constant communication with our community, and through those conversations, able to connect the dots to identify the major issues around and solve the problems. And so through your contribution today, actually, in the chat box, we're going to ask you to start sharing some of your experiences that go along with what we're talking about today. Because through that information, we will be able to further explore what your early onset was like, what your challenges are like, in addition to the wonderful people that we're going to be talking about today. Because really only when we communicate and we share our stories are we going to really be able to expedite that early detection. And then the other component is really advancing precision medicine. We're not going to get so much into that today. We'll talk about that a little bit more in part 3 of this series, which will be a Facebook live chat in April. But the idea is really about focusing in on why we are unique in these subgroups. And that deals with biomarkers and even genetic testing, which we'll talk about a little bit today. So those conversations we have in combination with moving forward towards genetic testing, biomarkers, precision medicine, all key to this early diagnosis. So we could move forward to the next slide, Miss Katie. And I would like to introduce for you, we're going to talk to a few wonderful people today. I'd like to welcome Parker, Rochelle, and Linda. Are you all 3 on the line? Could you say hello?
Hello, this is Linda.
Hey, this is Parker.
And Rochelle is here too.
All right, well, welcome. Thank you all so much for taking your time out today. I'm gonna go through a few things with these guests today. And if you look at the bottom, the topics, we'll start with disease onset and detection to diagnosis. Then we'll talk a little bit about typical versus atypical disease, and then diagnosis to treatments or hard to treat AI arthritis, and expediting a diagnosis. And again, I will encourage you who are tuning in to please feel free to share your experiences along with what you hear with the people who are sharing today, because again, together, the more we share, the more we'll be able to come up with some solutions. So I'm going to start with, first I'm going to start with Linda. And so Katie, if you could advance the slide, please. Thank you. So the first we're gonna talk to Linda. Hi, Linda. Thank you again so much for joining.
Hello.
I wanted to just something that we're all familiar with are onset stories, and I'd like you to just take a couple minutes to share your experience of onset to diagnosis, if you would.
Now, first of all, I also want to say thank you for inviting me to do this. This is so wonderful to be able to get the word out to everybody and get the knowledge out. So I really appreciate this, that you guys are doing this. But as it's been a struggle my whole life. Mine started in my early years in grade school. My fingers would randomly swell, my ankles would hurt. Nobody knew. My mom considered it growing pains and brushed it off, as most parents do. I mean, it's just normal, typical kids. And it slowly went away, so we never thought anything more about it. And then in junior high, I was pretty much symptom-free. But then in high school, about my junior year, I started getting back pain, legs pain. I'd wake up, my right elbow wouldn't straighten out. I developed fluid nodules on the back of my wrist, which I think that was the most important feature that made them actually say, oh, there is really something going on here. We need to figure out what's going on. My mom took me to several doctors, doctor after doctor, over 2 years. Went to a neurologist. He said that the damage in my back had already started, and he referred me to a rheumatologist. And somewhere in between there, I was also sent to a psychiatrist, which did biofeedback and said that it was a lash out and stress that I actually didn't have in my life, but that's what he determined.
Of course.
And, totally brushed me off. But luckily my mom kept pursuing, went to the rheumatologist. He said he pretty much thought he knew what was going on based on what everybody else had done and said, and what his findings were. He drew labs. He took the fluid out of the nodules and sent it off for test. And I went back for my follow-up appointment a week or so later, and he said, diagnosis is confirmed as JRA. And he based that on my symptoms and my positive ANA. And at that time, that was the factors for diagnosing JRA. And I pretty much kept that diagnosis, through most of my adulthood until they switched it to rheumatoid arthritis.
Okay.
But and at that time there was no treatments. So I was given aspirin and, multiple different types of aspirin because they put me in sick on my stomach, but there was nothing else they could do at that time. And, I was stuck.
Thank you so much for sharing that. I know, I know it's always difficult. We say it so many times, but it never gets easier to share it. So thank you for doing that. One thing that I wanted to focus on that you were talking about, because of our conversation today and really exploring this early disease onset and what kind of similarities we have, what's typical, what's atypical, based on the symptoms and signs that now about juvenile arthritis or rheumatoid arthritis. What were you experiencing that you think were fairly typical features?
As far as typical, I would say that would just be the nodules and the pain. But, there was other things like fevers, and I had multiple bouts of mono that they couldn't explain, and things like that they just didn't match up. And
right.
1 + 1 didn't equal 2. Right.
I know you had mentioned the finger swelling as well. And those would be kind of typical. And then the mono could be one of those things too that I think atypical that might throw somebody off and send you in a completely different direction. So I think it's really important for everybody when you're talking to people who are struggling with diagnosis, let's all kind of stay as educated as we can on some of these things that are overlapping. And then the things that maybe seem atypical, it doesn't mean that the person doesn't have this diagnosis. It just may mean that we all have different triggers or different genetics, or there's things that also could be happening. So I think that's really important to point out. You also mentioned, Linda, being RA negative. And in the 1980s, that was a requirement really for a diagnosis. But you did get a diagnosis, and that's good. But you mentioned when we were talking previous to this that did make you somewhat atypical. And that's something we even hear today. Oh, your blood work's normal, so you must not have it, right? Other than the blood work or the mono, or is there anything else that made you atypical, or that could have contributed to a delay in diagnosis?
Other than the fact that the symptoms didn't match, I mean, it just, like you said, it threw the doctors off, and and then the negative RA was one of the big ones that I've even now, within the last 10 years, I went to a new rheumatologist and they did my labs and all that, and they said, you don't have RA.
Oh.
And I was like, okay, I've had this for 30 years. Now you're telling me I don't.
I
made them run further tests, and they determined that yes, it was correct.
Right. And that's something, I know we don't have time to break out and talk about that today, but I think that should probably be a continued conversation in the Facebook Live. It's something we're seeing all over the place now. Progression, you're getting a little bit better, or you don't have the blood work and you change rheumatologist. That in itself is another issue. Thank you for that, Linda. I'm going to turn over to Parker for a few minutes. Hi, Parker, you still there?
Yeah.
Yeah, okay. Parker, your voice got high. So Parker, I'd like to, same question that for Linda. Could you tell us a little bit about your journey, your early onset? I know you were young, but from what you remember, your early onset to your diagnosis?
Yeah, so all of this, well, we think that all this started when I was 8 years old, but looking back at it, we're starting to realize that this probably started when I was around 2.
Wow.
Because I have pains now that I can remember. These were pains that I had when I was little. I used to wake up in the middle of the night with like what we thought was cramps in my feet, and my mom would say, she would say, eat a banana, walk it off, and then go back to bed.
Wow.
You have a cramp in your foot.
Yeah.
And I would do that. I'd eat a banana, I'd walk it off, I'd go back to bed. And, you know, I wake up now with that same exact pain in my foot. And, you know, looking back at it, I think that was probably my arthritis.
Mm-hmm.
So, you know, we think I probably had it since I was 2, and we just never caught it. But when it started getting really bad was when I was 8 years old. And that's when things started getting bad. I wasn't able to do sports anymore. It progressed pretty bad, and then it took about 2 years to diagnose me. I got diagnosed when I was 10. By that point, things were pretty difficult. I was put on pretty high doses of steroids because that's all they really knew what to do with me. Unfortunately, my doctor wasn't the greatest. They didn't really want to put me on any biologics, so they just put me on steroids and high doses at that. So I was on about 180 milligrams of prednisone twice a day. So I went from being about a 60-pound boy that loved playing sports to about a 120-pound boy that didn't get to play sports anymore. So it was difficult. And at first, you know, I went through a lot of symptoms. My symptoms weren't the same as everybody else's symptoms because I have systemic arthritis, which isn't the typical type. So I had a lot of the systemic features, which is like the fevers and the rashes. So I had a lot of that. So we would actually end up going to the hospital a lot because I would just be completely gray, my whole body gray, or my whole body would just be like purple. And we would go to the hospital because we'd be like freaking out. Like I would be taking a bath and my mom would be like, my son is like a ghost. I would just be completely gray. So we would rush to the hospital. We'd get there and they'd be like, ma'am, your son is fine. Like nothing is wrong. And isn't that just always the way? Like by the time you get to the hospital, nothing's wrong. And these people think we're crazy. So eventually we started documenting it. We would take pictures and we would write it down and we would record what was happening. And we brought these in to my doctor and we brought the pictures in and showed them. And since we were documenting it and brought the pictures in, and showed them, they were able to point out to us that these look a lot like systemic features from systemic arthritis. Mm-hmm. So that's how we were able to figure out, in combination with the pictures of the rashes and that I was getting fevers literally every day, that it was seeming like I was having, in combination with like all my joint pain and swelling and all that, systemic arthritis. So we were able to figure that out. So
thank you for sharing that, Parker. And that's really important to point out exactly what you just said. Like it was atypical of juvenile idiopathic arthritis, yet, because that's autoimmune, yet autoinflammatory, which also often is more rare as well, that there's high spiking fevers and rashes are more of a trademark or typical. So finding that typical on you was almost having to go away from the more popularized JA, which that's just really, again, a good point to to stress that this whole atypical versus typical, we just really need to keep sharing and communicating and logging that, and smart too for doing your chart. Let me just a follow-up to that. So you mentioned some of those typical. I think when we talked before, did you say too you were sort of atypical because you didn't have positive blood work either, did you?
No, none of my blood work came back positive. The only thing that came back positive was actually something called Sjogren's. So for a while they thought I had Sjogren's. But yeah, nothing came back positive. So
another example of you know, I think too many. I think it might be interesting to do a follow-up poll after this, maybe on social with all of our groups, and just ask really how many of you were told, you know, or were delayed because of this, well, your blood work is good, you're fine. I think it's happened to a lot of us. I know it's happened to me as well. It was part of the reason I was delayed. Quickly, what about you, Rochelle? As a parent and a person who speaks with other families all over the country, or well, the world really, based on what you know now, what would you say are some typical symptoms or disease features that parents and families can look out for?
Well, you know, for Parker, he did have some white blood cell count issues and swollen lymph glands. So those were two things that actually led us down the path of it. This could be lymphoma. And I think I hear that from the majority of parents, that they often get referred to hematology or an oncologist because there's something that just isn't quite right with their blood work, and they're thinking that it might be cancer or lymphoma or something related in that way. And it's interesting how many families have to go through kind of an exclusion of other diseases before they land on the correct one. I mean, we went through that. We went through fibromyalgia. We went through MS. He was seeing a psychiatrist and a neurologist, and, you know, nobody could quite figure out or put all the pieces together. And to me as a parent, that got very scary because at one point in time, it almost felt like they thought, well, I know they thought we were making everything up. And I think we're not alone in that. I'm hearing that from a lot of families where they're told that their child is either trying to get attention, or they as a parent are trying to get attention, or that it might be Munchausen or Munchausen by proxy. And that's a scary place to be in as a parent. Mm-hmm. And then when you do find out that there's a diagnosis, and, you know, we almost lost Parker and he had to be hospitalized, you know, that's scary that the pediatricians or the specialists, even some of the, you know, very specific specialists like neurology, they actually don't have the knowledge about autoimmune diseases and autoinflammatory diseases, or rarer conditions in children that may not present like they see every day.
Mm-hmm. No, those are really good points. Absolutely. And again, we'll definitely start breaking out and talking more about that, I think, too, in phase 3 of this collaboration. Thank you for that. I'm gonna toggle back to Linda here, because we're gonna move forward to kind of treatment challenges and talk about those last 2 bullet points, which is diagnosis, the treatments, hard to treat AI arthritis, and expediting a diagnosis. So Linda, once you were finally diagnosed, tell us a little bit of what your treatment plan looked like.
Initially, my treatment plan was nothing. I mean, other than aspirin for several years, on and off different aspirins. The gold shots had come out, but I was too young for those, and they were not recommended. And he did not want to give me any prednisone at that time. So I didn't get the privilege, or not privilege, but of getting relief from at least that during the time. All I had was aspirin to go by. Mm-hmm. But as I got older, and then when it came back and showed itself again in high school, that was when the aspirin was only available. But then when I got a little bit older, I had it flared for a while, and we did Plaquenil at that point. It helped a little bit, not much. Methotrexate, not much. And then I got pregnant, and luckily after pregnancy, I was in remission for several years, but then it came back with vengeance. And we started off with, a doctor had recommended a bio to me. At the time, they were brand new. I was scared to death of anything brand new, and I did not want to take it at that point. I wanted to wait till it was out for a while.
Mm-hmm.
So my arthritis finally got to the point where I had no choice. I mean, we exhausted all other options, and I decided to go ahead and start with a bio. And we start out with one, waited 3 to 6 months, nothing. Another one, 3 to 6 months, nothing. And I just basically went through that down the list and trials and errors. Some I had reactions to, I couldn't take any longer. But I never really got relief from any of them. And as of right now, I have been through every single one there is, and awaiting new ones. Still without any relief. And I feel that if I would have been treated initially with these drugs that are available now, my outcome would have been totally different.
Yeah, I mean, you do bring up an interesting point. At the time, biologics were new. Little was known about their use. That's scary, like you said. But now it's kind of a catch-22. It's a really interesting situation now that we're seeing they have been out for a long time. Yet there are some, and justifiably so, concerns about side effects, long-term use, that now are the reason that a lot of people will stop starting, will not start them. I know we've heard a lot, people, well, I'm just going to wait till I get worse until I absolutely have to, which we know is then you risk that window of opportunity where the inflammation is now went through the window and it may be harder to reel it back. Understanding we're not giving any medical advice or recommendations whatsoever for using any kind of treatment, just simply based on your experience, how important is it for patients and whatever that treatment may be to find and start the right one as early as possible?
Very important. Diagnosis as soon as possible, treatment as soon as possible. Because I feel that's what the nail in my coffin was on mine, is that I waited so long. Well, not the fact that there wasn't anything initially,
right,
and the fact that I actually waited even longer once they came out.
Okay. Well, thank you. Thank you for sharing that. I'm going to go back here to Parker, and just same question. Once you were finally diagnosed, you did mention it a little bit in the previous question, but what did your treatment plan look like, and how has it worked for you?
So like I said, the first doctor I had didn't really like the biologic option, which was unfortunate, because I feel that if he did, my disease probably wouldn't have progressed to where it's at today, and we could have stopped it, and I wouldn't be where I am, which would have been nice. Unfortunately, he did not want to use biologics, and my disease got pretty bad. And now I'm where I'm at. So we switched doctors, and things got better. When I got to my new doctor, she saw where I was. She looked at me and said, "There is a problem. You should be on biologics. You are very bad." And at that doctor's appointment, she gave me a shot of Enbrel and methotrexate right there. And I started biologics that day. Since then, I have tried just about every biologic out there. They work for me for about a year at a time. That's about the longest they work. I've done infusions, I've done shots. They help. The problem is I have both ankylosing spondylitis and systemic arthritis. So ideally, I would need to be on 2 biologics, but unfortunately, insurance does not approve being on 2 biologics because it's too dangerous. And I need to be on 2 because I need 1 one to target my systemic features like the rashes and fevers, and one to target my SI joints to help with that. So they don't get inflamed and don't permanently fuse.
Right.
But since insurance won't approve that, I can't. So right now I'm in a situation where I have to decide what's worse, having my SI joints be inflamed or having the systemic features flare up right now and my heart and lungs be really bad.
Right.
So I kind of have to just choose which one I want to be bad at which time. So like right now I've chosen to be on a med that's helping my systemic features.
Right. No, what an interesting but relevant point that you bring out. Once you start to develop the comorbidities too, it's almost like, I know in our pre-interview you said something that really caught my eye. We're chasing the disease, and I just think that with that's just such an important thing to remember, that sometimes with patients like yourself, it makes it really difficult to treat because you're just chasing the most immediate thing at the moment. And you also did a clinical trial too.
Yeah, I was on a clinical trial in 2013. I was on the rilonacept trial. And that drug worked for me better than any other drug. It lasted 2 years, which is longer than any biologic that I've been on. I was the only kid in Florida on it for a while because it wasn't approved for children. The only reason I was able to be on it was because I was on it for the study, and then they let me stay on it because of that. Mm-hmm. And it worked for a long time, but it's just something with my body. Once I stay on the biologic for a certain amount of time, my body just starts to adapt to it, and it just doesn't work anymore.
Yeah.
So I had to eventually switch off of it. So right now I'm on no, okay, never mind. Yeah, right now I'm doing good. I have things under control. Like, this is probably the best I have been in years. I've gotten to a point where I haven't used my wheelchair for anything besides Disney, and to me that's amazing. I've had, in the past 4 years, I've had 6 ankle surgeries, which has been tough, but I have been able to walk everywhere I have gone besides Disney. So that has made it all worth it for me. So, you got to just take things as they come. And for me, it's been hard, but I've been going to physical therapy and I've been getting through it. And it's just been, it's been good.
That's great. That is so great to hear. Well, just to wrap up this segment, because we're going to move on to the next presenters. But before we do, just a quick walk through here. But I'd like all three of you, Linda, Rochelle, and Parker, to just say a little statement on this. What do you think patients or families can do to help people get diagnosed quicker? Linda, let's start with you. You have some advice.
I think that the primary cares need to know as much about diagnosing patients with this as the rheumatologists, because it's going to start there. Mm-hmm. Primary cares, family doctors, and also public education. Okay. Getting the word out, letting people know if you have this, this, and this, please check into this, this, and this as soon as possible.
Absolutely. Yep. Rochelle, what about you? What do you think patients or families can do to help expedite diagnosis?
I think that, because technology is in our world now, I think taking pictures, taking videos, those are powerful. And also keeping notes and looking for trends, just keeping notes on what's happening with your child so that when you do see the doctor, you have that to show them.
That's great. And then Parker?
I think just trust yourself. Like I thought it was growing pains when I was little, but I part of myself knew it really wasn't growing pains. So I think just trust your gut. If you think that it's growing pains, you know, I was like, I don't think growing pains last 2 years. So, you know, just trust yourself. If you don't think it's something, just look into it further, you know, trust your gut.
That's great. Okay, and so I'm going to thank you all again. I'm going to turn it back over to Katie, and we saw a comment had come in, and I just want to clarify, make sure that it was a question on addressing adults as well. It happens that, yeah, we do have these panelists that did have juvenile arthritis onset, but yes, please, if you're online, share your stories, because we need to, adults, children, we're all in this together. The more we communicate, the more we talk, the more we'll be able to connect the dots. So please, we encourage you, if you're online, adult onset, juvenile onset, whenever you had onset, start sharing your stories, and together we'll create some answers. So.
Absolutely, Tiffany. Because you never know what your story could help do for others, like, you know, similarities, and oh yeah, I have that too. So it seems simple, but it can be very powerful. So yes, please do share your story. And thank you, Tiffany. And thank you, Parker, Rochelle, and Linda, for not only taking the time, but for sharing your story, and excellent advice as far as more education and awareness and knowing your body and taking notes. And especially, I love the idea of videos and pictures to show doctors, because sometimes on the day of your appointment, you could feel absolutely fine, and doctors might not sort of see or truly understand what you're going through. So great advice all around. So now we are going to talk about genetic testing and clinical trials, and getting, again, the best possible treatment and care for you. First up, we have Katie Crosby, a certified genetic counselor who works at the Children's National Medical Center in Washington, D.C. So, Katie, if you want to maybe introduce yourself and talk a little bit about what exactly that means to be a certified genetic counselor.
Sure, thank you. Yeah, I work at Children's National in DC, and we are primarily a pediatric institution, but genetics is one of those fields that's pretty rare. So we see patients of all ages, children and adults, here in our clinic, and our focus really is on rare disease. And so genetic counselors have very special training. We're trained in genetics and also in counseling, and our job is really to try to help patients and families to figure out, is genetic testing right for you? What kinds of genetic testing is out there that, you know, might be relevant for you? So kind of the pre-testing is a big part of counseling. And then also, once someone has genetic testing, to try to really educate families on what does that testing mean for you specifically, for your health. Also, what does it mean for family members, for inheritance, and just kind of helping families through that process of, you know, what testing can we do, and what happens after that. And, you know, we're still always advancing in genetics. We definitely don't have the answers to everything at this point, but hopefully today I can share a little bit about when genetic testing may or may not be helpful.
So you kind of touched on this a little bit, but what can genetic testing do for a rare disease patient in particular?
So rare diseases, you know, by themselves, that's a term that we like to use a lot. And, you know, there's known to be over 6,000 rare diseases. And so some of them we know are genetic, some of them we're not sure at this point, but over the last 1 or 2 decades, genetic testing has really exploded. So I think that genetic testing for any patient can really help in kind of narrowing down the diagnoses. So I think some of you touched on this before, that, you know, sometimes you're diagnosed based on just a symptom. So then someone has, you know, 10 or 15 different diagnoses, when really it's one rare disease. So I think in certain conditions, we can find a specific genetic cause to say, this is your diagnosis, this is your rare disease. and you don't need to go by, 1,000 different diagnoses. But, speaking specifically about autoimmune diseases, it's a little difficult in this realm because we know that these diseases tend to run in families, and there's definitely a big genetic component, but we also think there's, environmental and other factors. So in those types of diseases, sometimes the testing is not specific. So you can't come in necessarily to a genetics clinic and say, I want to be tested for, this one autoimmune disease. But that doesn't mean that there may not be a different underlying condition that is genetic. So it may, like I said, narrow down kind of what the diagnosis really is.
And how can genetic testing be empowering for a person with a chronic illness?
So like I talked about with kind of narrowing down that diagnosis, if someone has a specific genetic diagnosis, meaning we looked at specific genes in their body, we found one gene that has a genetic change or difference that we know causes a disease, then that can really lead someone in the right direction for care and for management. So whether that's just finding the right doctors to see, finding specific support groups, linking up with clinical trials based on that specific diagnosis. So I think it can really be empowering to have some more concrete answers and then to lead you to the right place. Whether it's a clinical diagnosis or what we call a genetic diagnosis based on a genetic test, either way, like everyone said today earlier, Linda and Parker, once you have that diagnosis, you at least can hopefully move in the right direction for treatment.
Fantastic. So when in their journey should a patient seek out genetic testing?
So it really is case by case, but I think kind of like Parker had just said at the end, you really need to trust your gut. If you feel like your diagnosis is wrong or you haven't received a diagnosis, genetic testing may be a good place to go. I would always recommend talking to your doctors, your specialists, your primary care, whoever it is that you're seeing, and say, do you think genetic testing would be useful? And like I said, it's not useful for everyone, but for example, like Tiffany mentioned, some patients who have Farber disease are misdiagnosed with a juvenile arthritis. So in that case, without genetic testing or genetic evaluation, they would never have that diagnosis. So really, if you feel like the diagnosis is incorrect or you just don't have the full picture or there's something missing or treatment is not clear, that may be a time to seek out genetics or different types of genetic testing.
All right. And then finally, if someone wants to learn more or get a better understanding about this area, where can they go?
So I think really finding a geneticist or genetic counselor or genetics clinic is the best place to go. And I say that because there's a lot of information on the internet. There's a lot of, direct to consumer companies, but they may not be specifically, what you as a patient or a family need. So there is the National Society of Genetic Counselors. You can search on their website for a certified genetic counselor. You can also look at any major medical institutions. They usually have a genetics clinic. And like I said, even if it's a pediatric institution, they probably see adults as well. So really finding, a geneticist, a genetic counselor, a genetics clinic, that would be what I recommend, to ask your questions in person and really get, accurate information.
That is some great advice. And again, for anyone listening, we are going to have all that sent out to you later. And Katie, thank you so much for talking to us today.
You're welcome.
And next up, we will talk to, Lily Stairs. She's an amazing patient advocate. She's working for Clara Health, Savvy Cooperative, and she's a board member here at AARDA. So Lily, if you want to introduce yourself maybe a little bit more and maybe give a brief explanation as to what clinical trials are. Lily, we might be having some technical difficulties. While we try to get her audio up and running, so a little bit about clinical trials. There are different versions, different types. One are interventional trials, where the patient can access treatments not yet available through standard care, and that they test new treatments or new ways of using existing treatments. So especially with autoimmune disease, one biologic may be tested to see if it can help a different autoimmune disease. So it could possibly start off treating rheumatoid arthritis, but may find out later that it could be also a benefit to someone with psoriasis or any number of the other autoimmune diseases. Another type, observational trials, they allow researchers to follow patients' health and learn more about a condition. So patients in those trials generally continue with their current treatment, and those would include natural history studies. All right, and then there are different phases of clinical trials. The first one, as you can see, the span is about a few months, and then they usually test dose and safety. Phase 2, it spans a little bit longer, and then that tests the treatment efficacy. And then phase 3, it spans several years, or many years, which tests the treatment for standard of care. And then phase 4 is over the course of several years, and that tests the safety and quality of life over time. Tiffany, are you still there?
Yes, I'm still here.
I'm going to try to call Lily. So if you want to maybe start.
Hi, Katie. Can you hear me?
Perfect. Great timing.
Oh gosh, I am so sorry to all of our webinar participants. I have no idea what happened or why I wasn't able to access, but that happens with technology sometimes. So here we are. We've got to roll with the punches. But
Yes.
It sounds like Katie did a great job at giving the overview in my absence. Katie, thank you so much for taking over. Katie is an amazing addition to the AARDA team, and I trust that she gave you a great walkthrough of clinical trials thus far. So Katie, should I pick up on this slide? Why consider a clinical trial?
Yes, go for it.
Awesome. Okay. So, when we're looking at clinical trials, there's a lot of different reasons that a patient might consider enrolling in one. And so we really do want people to understand all of their treatment options available. So when you are first diagnosed, oftentimes, and as we've heard within the autoimmune space, you'll get a list of different treatments. Some of them, are disease modifying drugs and biologics. But for people like we heard from Parker, he was saying that keeps building up immunity to some of these different biologics. And so for many folks, a clinical trial can actually give you access to some of those newer drugs that maybe don't yet exist on the market and could actually be a better fit than what's currently on the market. In many cases, for rare disease patients, it's often the only treatment available because they haven't come out with, there's not often, unfortunately, not often a whole lot of treatment options or any treatment options available for rare disease patients. So it can be a great way to access treatment there for rare disease patients. Again, tried and failed a few different therapies, much like Parker's scenario. There could also be a scenario where some of these clinical trials have drugs with less side effects than what's on the market. So that's another reason to consider it. Another interesting reason that we often see people turning to clinical trials is that, unfortunately, they may not be able to cover the cost of their care, or they're struggling with their insurance to get on a drug that's really the right fit for them. And so this is where sponsors who are covering the clinical trial might actually cover the cost of treatment and the travel back and forth. You do have to confirm with them on this. It's not always cut and dry, but frequently we do see sponsors are covering cost of clinical trials and cost of that medication. If you've exhausted all your FDA approved treatment options, clinical trials could be a great option. If you're interested in finding a co-therapy to complement your current treatment, so maybe you're on a treatment that's gotten you 60% of the way there, but there's something else out there that could get you that last 40% so that you're feeling back to 100%. And then help advance research about your condition and help other people down the line. These clinical trials, without them, we don't have all of these treatments that are currently approved. And so not only are you potentially getting yourself a life-changing treatment, but you could be changing the lives of people down the line. And so, Katie, if you want to go to the next slide. We've put together a couple of resources here. A couple of months back, I actually worked with AARDA, and Clara worked with AARDA on a self-advocacy and clinical trials webinar. So if you want to get a deeper understanding of clinical trials, you can go ahead and listen to that and see the slides there. We've got a link. And then also Clara Guides. Clara has put together a whole set of resources for patients who are interested in better understanding clinical trials. And I put a few of our popular ones in there. So safety and regulation, what it's like to participate in a clinical trial, and how you might be able to find a pediatric clinical trial specifically, because sometimes that can be even more difficult. So that's my overview. And again, I apologize that I missed the first half, but it sounds like Katie has got you covered. And feel free to reach out to me at any time with any questions.
Yeah, technology, you can't live with it and you can't live without it. But like Lily said, our previous webinar that the link is here, and we'll send it out to you again. It goes much more in depth, and it covers everything in Lily's own words, and she is most definitely an expert on all things clinical trial, and I highly recommend it. I found it fascinating. So thank you, Lily, for that. And we're actually almost out of time. So to wrap up, we hope that you found this information useful. That's our goal. And to keep the conversation going, again, please join us for that Facebook chat on April 5th. Again, it'll be 3 p.m. Eastern time. So right here, right at this time in a few weeks. And it'll be our last event in this series. Again, that was with the International Foundation for Autoimmune and Autoinflammatory Arthritis, the Purple Playas Foundation, Clara Health, and AARDA. And I will let Tiffany explain a little bit about a survey that we have coming up to sort of help us understand more about you.
Sure. Yeah, just a quick note. So for all of you who have attended today, I know in the follow-up, Katie and Ari will be sending you some more information about this survey if you'd like to participate, and we'll also be promoting it on social media as well. But as a follow-up, what we've been really wanting to do is a little bit of research more into exploring these potential issues associated with early detection and proper diagnosis, and why are some of us so hard to treat. And so we're really working hard. IFAA has created a research survey, probably about 20 minutes long, so it's a little bit in depth, but we hope the more people that contribute their stories and talk about their early symptoms, their early presentation, they're atypical versus typical. We'll talk about that in there. Together, we'll analyze that and maybe start to create some answers and even some early detection modules that we can use to help educate primary care physicians as well. And we want to also thank the Purple Playas Foundation, because they will also be helping with some specific breakout information for the juvenile versions, because IFAA is going to handle more of the adult onset difficulties, but they're going to contribute. So that'll be available this week. So please, we really hope that a lot of you will participate in that.
Yes. And thank you so much, Tiffany, for joining us. Again, our Condition Confident Facebook chat will be happening Friday, April 5th. And once again, thank you to everyone who helped put together this webinar: AARDA, Purple Playas, IFAA, Clara, and then an extra thank you to all of our speakers today for taking the time out, especially on a weekend, to participate and share their story and their knowledge, which is invaluable. And to everyone listening, thank you for participating. Thank you for joining us today. We hope that you are doing well and that you stay strong, and have a great rest of your day.